Thank you very much for the introduction and for the opportunity to chair this roundtable session. I think we've heard a lot today from this formidable group of speakers about, I think, on one hand, how much hope there is in, the way that we approach pandemics and infectious disease preparedness going forward, but also how much complexity and challenges still lie ahead. My name is Matthew Miller. I'm Executive Director of Global Nexus at McMaster and the Michael DeGroote Infectious Disease Research Institute. I'm also a Canada Research Chair in Viral Pandemics and co-director of one of the national pandemic preparedness hubs. Maybe to start, I thought it might be prudent to talk to the panel about this juxtaposition of the issue of rapid response versus prevention. And I think we heard it at the beginning from Dr. Halton about, the really excellent work that's happened, especially over the past few years to try and meet the 100-day mission that CEPI has put forward. And then Dr. Peiris also highlighted, I think, the real importance of thinking about avoiding pandemics from happening to begin with by focusing on the human-animal interface where we know the risk is highest. And so I guess maybe to Professor Halton to start, maybe you could offer some thoughts about what that balance is and whether, as we become more successful in responding rapidly, is there a need for us to shift our mindset to one where when spillover events happen, we view that event as a failure in itself. So the need to respond is really a failure to prevent.
It's an exceptionally important question. And what I would say is it's not either or. Essentially, we need both. And I think the commentary made about simple things that can be done from a One Health perspective. And we know that the global negotiations on the pandemic treaty, One Health is a key feature of those discussions. So it's incredibly important. And I agree with you, if we could get to a world where if we have a failure from a One Health perspective, we all regard that as being the system not working. But we need to also be ready to respond. There are things at the moment, globalization, the reduction of habitat, everyone in this audience I'm sure knows these things. So we see the both as being completely complementary, and to use a colloquial expression, we need to walk and chew gum.
Wonderful.
Yeah, I'll just add, I absolutely agree. Our friends at the EcoHealth Alliance based in New York estimate that new coronavirus are spilling over from bats to people, either directly or through a secondary intermediate animal host, 66,000 times a year. So as we speak, thousands of people are getting infected with new coronavirus. So that's happening, and the problem is we're not doing nearly enough surveillance to really know this at a very granular level. We still never really have done the outbreak investigation for COVID-19 that needs to be done to really understand at a very detailed level what's happening. And this means absolutely walking and chewing gum at the same time. It means having lots of new vaccines ready, at least prototypes, and of course both for the emerging pandemic threats and what's happening, for instance, on our US Gulf Coast, is through climate change and urbanization, this huge uptick in dengue, Zika virus infection, or a Puche virus, so that's going to be another reality. I think probably the most important thing to think about is we're always trying to do this on the cheap. I mean, the fact that Professor Halton has to struggle for funds is unconscionable, right? I mean, if we haven't learned by now that the public health impact of COVID was only one part of it. It was the economic impact, the global security aspect, and yet, people think nothing of spending billions of dollars on weapons and defense, and yet we're supposed to deal with these pathogens on the cheap, and I think we've got to figure out a way to change that mindset.
Thank you so much. So we've talked a lot today too, I think, about vaccines, and rightly so, as really a frontline countermeasure to prevent infectious disease spillover, but maybe slightly less so about some of the other countermeasures that are really essential to both controlling and responding to infectious disease. And I think One thing that maybe some of us who have been, for example, in the influenza field for some time have recognized are some of the inherent limitations around our sort of historical pharmaceutical approaches to controlling some of these outbreaks. So as an example, I think while antivirals have been extraordinarily successful for treatment of chronic conditions like HIV or hepatitis viruses, the clinical benefit of antivirals, direct-acting antivirals in particular, for things like influenza and SARS-CoV-2 were very, very modest. And in fact, in many of these pragmatic trials that happened around the world, what we ultimately saw was immune modulators were the most effective drugs, right? Dexamethasone was one of the first to pop out. So maybe for Dr. Fralick, I wonder if you might comment around the need for us to think inherently differently around the way that we approach the management and treatment of infectious diseases, and perhaps, you know, the need to focus not so much on the virus, but on treating the ultimate pathology of disease itself.
Yeah, it's a great question. So early on in the pandemic, there were many of us that wanted to do our own randomized trial. That was the wrong approach. So the World Health Organization identified, listen, there are existing molecules. We should be doing pragmatic adaptive trials for molecules that already exist, but maybe for a new purpose. Remdesivir would be the best example. And I think the pandemic taught us to question our assumptions. I would have been the first to say there's no way a steroid would be helpful for this virus, but so naive. Steroids end up being life-saving. So I think having these trials in place where we can add and subtract molecules when we realize something doesn't work, but starting with existing molecules, that's the fastest way to find treatments, and that's what we learned from COVID-19.
Thank you so much. A question in the audience?
Sure. Eleanor Fish, I'm a professor in the Department of Immunology and also at the University Health Network, a scientist. I hear what you're saying, and I hear what you're saying also, Michael. And I think the point is that what we should keep aware of, dexamethasone is very effective for its anti-inflammatory effects. When we're talking about treating or an antiviral during any sort of outbreak or pandemic, in the West, predominantly, what we do is we treat people once they're already symptomatic, and very often once they're already in hospital. At that stage, the viral phase of the disease is less important. So I would argue when we think about antivirals as a complement to vaccines, we need to be thinking about protection from infection, preventing transmission, early on in outbreaks, looking at exposed but uninfected people. And our immunology has taught us that there are already available relatively good viral agnostic immunotherapies we should think about, which we're not.
I completely agree. I think that's a wonderful point. And
just quickly repeat the question, and can people who want to ask questions please use Slido?
yeah, sure. So I will repeat the comment was that in the way that we currently approach treating infections, we're often deploying antivirals during outbreaks to treat people who are already symptomatic. And in the case of pathogens like influenza and SARS-CoV-2, once an individual is symptomatic, restricting the virus has very little clinical benefit, but treating the subsequent immune response has a lot of benefit. And so there's been a massive expansion in the number of immunomodulatory drugs on the market now. It's probably the fastest growing area of the drug market. And so this presents, I think, a really new opportunity to learn about how those might be deployed to mitigate disease. I think, yeah, so I'm going to actually redirect a question to Dr. Peiris and Dr. Subbarao, because I think this is maybe particularly an interesting case study as we think about prevention and control of highly pathogenic avian flu at the moment. We know that neuraminidase inhibitors, for example, work very well as prophylactics, but are infrequently used that way. And so I'll pass the floor over to Dr. Peiris and Dr. Subbarao to add their comments.
Yeah, so the experience with SARS-1 in 2003, the initial anecdotal reports of patients who are severely ill being treated with corticosteroids, making a dramatic recovery, were pretty real. Mm-hmm. But then what happened was clinicians thought, oh wow, we should treat these patients earlier and earlier and earlier. So as soon as the diagnosis was made, that is 2 days into symptoms, 3 days into symptoms, they were getting high-dose steroids. And clearly that was not the right thing to do. Right. And of course, in Hong Kong's own experience, after the whole outbreak was over, there was a lot of inquiries into all the side effects of corticosteroids. So, corticosteroids really got a bad name. Now, if you look at the clinical trials from the UK, which showed the benefit of corticosteroid use, it was beneficial in patients who were oxygen dependent.
Yes.
In fact, if you look at the data for the non-oxygen dependent, although it was not statistically significant, the trend was in the reverse direction. So I think 2 points. I think, yes, immunomodulators clearly have a role. We really need these large clinical trials, mega trials in order to get these signals. But we have to use them with caution.
Yes. Dr. Subbarao.
So I would add 2 things from the antiviral standpoint. One is that I think we have to think about what the disease is, what the kinetics of replication are, and whether there's even enough time or room to use antivirals as a treatment strategy. And the second thing is that once you identify an antiviral that works, getting it to the people who need it when they need it is very challenging in a pandemic scenario. So in New Zealand, for instance, they have made the neuraminidase inhibitor, oseltamivir, over the counter. It's available over the counter, so people don't have to wait to get in to see their physician to buy it. So I think in the event of a pandemic, those are some of the practical things that we need to solve, because there's no point having a drug in a stockpile if it's not where people need it, so that they can institute treatment as early as possible.
Maybe a question now for Dr. Kang and Dr. Gommerman. I think one of the things that I think the vaccine field at large came to recognize during COVID-19 was maybe to temper, but also to expand our expectations about what a good vaccine should do. As someone who lived in the flu space for a long time prior to 2019, I think in vaccinology, we've been disproportionately focused on prevention of PCR-confirmed infection. And the reasons for that are somewhat intuitive and straightforward, because that's easy to measure in pivotal phase 3 trials. It's often much more difficult to measure severe outcomes because those tend to occur at low frequencies, and so it's hard to gain statistical power. But nevertheless, I think what we saw during COVID especially, right, was that even when our vaccines started to diminish in their protection from infection, they still held up quite well against severe disease. And I think we know that this story is true across other disease indications as well. So maybe if you could add your thoughts around how our expectations of vaccines have maybe shifted or should shift in light of what we've learned.
So I think SARS-CoV-2 vaccines actually performed spectacularly well for something that was targeting what is essentially a mucosal pathogen. So you're giving a parenteral vaccine, but you're inducing a response that is preventing severe disease. And in a lot of cases, when you're recently vaccinated, decreasing infection as well. That is actually not the case with most mucosal infections. So rotavirus, for example, you only prevent severe disease. You almost do not prevent infection. In polio, you try to do both, but at least you prevent disease. So I think it's different horses for different courses.
Thank you.
Yeah, I would add that I think communicating clearly what your vaccine has been tested for, and the COVID vaccines were tested for protection against severe disease. And I think that potentially we could say that there were some lost opportunities in communication with the public that might have set us up for maybe some backlash. So I got my 2 COVID vaccines. I'm a good citizen. Why do I have COVID? So I think we can explain that as immunologists and as vaccinologists. We can explain that to the public in fairly straightforward terms so that expectations are managed.
Thank you.
But we can also do better with our vaccines.
Yes, absolutely. Dr. Peiris?
Yes, I think this poses a real challenge, because when the early clinical trial data came, say for the RNA vaccines, very impressive protection from infection, right? And basically mild disease, right? Not
Yes.
infection, from mild disease. We really had no data on protection from severe disease. So, and then I think in retrospect, arguably, we went a bit overboard trying to extrapolate that it'll protect from infection as well. And then it became obvious it didn't. So I think, the public does get confused. I don't have a solution to this because it takes a long time to get the severity data. And how we communicate that in that early stage, I think is a challenge.
Well, watching this unfold, in the U.S., the vaccines were approved on the basis of stopping symptomatic illness. Yes. But in the beginning of 2021, the Israelis showed that indeed you were stopping asymptomatic infection almost as well, 90% reduction, and virus shedding. And that was the basis by which the CDC said masks can come off. The problem is they didn't explain that. And this has been a pattern of communication from the U.S. Health and Human Services agencies. They don't give the underlying assumptions. They just take this very paternalistic view, these summary judgments on high. Then as this thing moved to the Delta variant, you were kind of losing that performance function against asymptomatic transmission. In fact, there was still some impact, but not as much. And that's why the masks had to come back on. But all of that wasn't explained, and I think that was a missed opportunity.
Maybe one last question? Okay, so this I'll open up to the panel at large, and this is certainly a personal reflection, but I think we've heard today about, really immense innovation and policy changes that are enabling us to intervene, particularly in more sophisticated ways with, vaccines and other types of pharmaceutical countermeasures. But in some of my own reflections and experiences on national and provincial committees, it also occurs to me that maybe the toughest area, and I think this resonates back to Dr. Hotez's talk especially, is some of the human aspects around compliance in particular. And one of the things that I think, even as an expert in this field, that I feel like we are really lacking are clearly communicated frameworks for trigger points around non-pharmaceutical interventions. I think in a lot of jurisdictions, this political pushback that Dr. Hotez mentioned really did stem from, reluctance to embrace mandates. Nobody likes mandates. But another issue with mandates, I think, in many cases, is that it was not clear what the rationale for sort of moving the goalposts were when there were different types of restrictions imposed. And this, it occurs to me, should be something that, is sort of the foundation upon which we build a response to future outbreaks, because of course in any future outbreak we're going to have to respond in a non-pharmaceutical way until pharmaceutical interventions become available. So I'm hoping maybe some members of the panel will just be willing to comment on this issue of creating these types of frameworks. Professor Halton.
Yeah, thank you. And the first thing I would say is everything is local and in context on this. It's worth reminding ourselves what happened in Japan. versus what happened in other places. In Japan, because of the social strictures on people not going out, potentially infecting others, they do this in any event. Mask wearing was pretty well accepted. People stayed home. They didn't need mandates to do that. And I think the point that you've made in your question, which is so much of this is about thinking about the explanation, Peter has just said this as well, being very clear with people why is fundamental, and the world is open for misinformation if you don't fill that void. And speaking as one who ran a national health system for 12 and a half years, I can tell you that if you don't level up with citizens, they aren't stupid, they can tell when they're being lied to, and so thinking about clear, consistent communication, including when things change, and I think there is a challenge for people with a science background to speak clearly and to make that compelling for people, because the people who we're working against do.
I am going to have to call an end to this wonderful discussion. Thank you so much, Matthew, for coming here and leading the discussion today. Thank you for the audience who's here. Thank you for the audience online. This is the end of what has been a fantastic Gairdner Science Week, and certainly I've really felt this morning we covered a lot of ground, looking back to where we were with pandemics and trying to remember to learn from our past mistakes and our past successes. There were successes, there were mistakes, and in the future we have to do better than we did before. So thank you, everybody.